sharing experiences, really important. Learning from each other, hearing from our expert speakers.
I want everyone to really take control of their health, because it's your body and your life, and if you're not in control of it, no one else will be.
Turns out that almost all pacemakers are completely fine to go through an MRI scanner.
Both septal ablation and surgical treatment show good results. It's safe, comparable.
HRT for many women is a lifesaver.
However, and it was a real shock, they told me I did need a transplant.
It's funny being a carer. You know, sometimes people don't take their medicines properly and you get cross at them. Why are you not taking your medicines?
I would say the next big stage in the development of this story was our understanding that this is, in many people, a genetic condition. So it's a heritable and transmissible disease.
So some of the pros of genetic testing are that we can find a causative gene change in some people.
Thanks, Stephanie. I'm going to walk around a little bit, so if you can't hear me, just tell me. And if I'm talking too fast or too Glaswegian, please put your hand up as well. I'll not take it personally, I promise. Given the topic of the conference this year, I'm actually not going to talk to you mainly about drugs. I'm going to talk to you about some of the human aspects around taking medicines, some of the problems that people have, how you make decisions about whether, when somebody offers you a treatment, whether you want it or not, how you take a wee bit of control and empowered to ask some questions, maybe if things are going wrong, maybe what you do when things go wrong, you don't want to take things anymore, what you should think about. So rather than talk to you about this is drug A, drug B, that's boring, you'll hear that every year at the conference. Let's talk about some of the challenges that actually impact on your life. So we're going to talk a wee bit about shared decision making. Like, how do we actually empower you as the patient to know whether this treatment that I might be offering you is a treatment that you want to take? And that might include things that you understand a little bit about risk, the risk of not taking it, the risk of taking it, which one's better, which one's worse, how that you feel about that. If we were doing this talk 30 or 40 years ago, the doctors would have written you a prescription, handed you it, and probably kicked your backside out as you walked out the door, and probably not really explained anything to you. We shouldn't practice medicine this way anymore. We should involve you. It's your body, it's your life, it's your end point, and we should be empowering you to try and be involved with that if that's what you want. Some patients actually still say to you at clinic, look, you just make the decisions and I trust you, and that's okay if that's what they want. But lots of patients want to get more involved now, and we'll talk a little bit about that. We'll talk also a little bit about medication adherence, like sticking to the plan, and why maybe patients don't stick to the plan. Can I ask here, can you go and stick your hand up if you are a patient? Like, so how many patients have we got? Nearly all. Have we got any carers here today? Like carers or family, couple? Any healthcare professionals? Okay, one. It's funny being a carer, first of all, too. It's funny being a carer. You know, sometimes people don't take their medicines properly and you get cross at them. Why are you not taking your medicines? We'll talk a little bit about why that happens. Because it's not as simple of you're not taking them and you should, and that's bad. How many of us have ever had an antibiotic and stuck to it properly and taken it beautifully in the course one? I certainly haven't too. That's good. Most people don't, because they've got a life to lead, like in between taking their medicines. Taking your medicines shouldn't be the thing that you think about every minute of every day. It should be living your life. And your treatments and stuff should fit around that as much as we can possibly do. We'll talk a little bit about polypharmacy as well. Buying things over the counter, herbal preparations, different bits and bobs. Because these are the kind of common questions that we'll get. It's hard. I could have come to you today and talked to you about ACE inhibitors and beta blockers and blood thinners and different things, but you all have different conditions. And it would have been hard to do that in an audience like this for really everybody to meaningfully take away things from it. Some of what we'll talk about today is from a couple of publications, and we've tried to put them up for people. This particular one's probably only relevant to the people in the room with dilated cardiomyopathy, but the principles is what we're going to talk about in the rest of the talk. So the first thing I want to talk to you about is shared decision making. And this probably sounds like a hippie concept, as if we should all have a hug. But it's not about that. It's your life, it's your body, it's your worry, it's your family. We're trying to make this work for you. And for all of you with the same problem in the room today, you might want different things out of your life, out of your treatments. That's okay. And maybe need to find out what it is if I'm going to try and help you get onto that. So what is shared decision making? There's lots of different definitions, first of all. But it's a process through which the clinical team, might be a doctor, might be a nurse, might be a pharmacist like me, might be lots of different members, but somebody in that clinical team and the patient share information about what's happened, what's wrong, how are you, how are you feeling, what do you want from your treatments. And they work towards a treatment plan that's based on lots of different options out there that are reasonable, and we can talk about what that means as we go on. And we try and align them with what the patient wants. Because what the patient wants is different from patient A to patient B. And it might be different at different times in that patient's journey as well, so it's not static. So there'll be some of you in the room that perhaps the main thing that you want is a family and to have children. And you're at the younger end of the spectrum. There might be some of you in the room that are very symptomatic, and what you really need is your symptoms treated. And you might have two people sitting beside each other with the same condition that want different things out of their treatment. So we have to ask you what it is that you want. We shouldn't just assume. I shouldn't assume anything about you. We should have this partnership that helps us make this. So what matters to the patient here is vitally important, because if you're a young woman with a cardiomyopathy and what you really want is a family, then let us know, because how we have to manage your treatment, including your medicines, if you're going to come to the pharmacy and get them, is going to have to be quite different from if you were really interested in your symptoms and you want every medicine known to man to try and make your symptoms better. So I shouldn't assume just by looking at you that you want one or either of those things. I should ask you. What do you want from this? And this only really works where you have a relationship with someone. You probably need to find clinicians that you trust, that you find relationships with. And these will be different. So some of them might be your GP. And you might have had the same GP for 10 years and really trust them, and they might know you and you might know them. That's brilliant. Some of them might be the cardiac MDT, like where I work, where you get to know somebody, you see them every few months, you really trust them, you get a relationship with them. Might be your community pharmacist as well, and maybe it's somebody that you can pop into on a Saturday when things have gone wrong or it's run out. But a relationship is what helps these decision-making processes. Because the very first time I meet you, it's hard for me to know anything about you. When I read it on a letter or whatever, when you first walk through my door. It's more about finding a way to understand what it is that's wrong with you and what it is that you want from whatever it is I can offer you. And that takes a little bit of time. We've done research on this. This doesn't tend to worsen anxiety or distress. Again, if we'd been doing this 10 or 20 years ago, they'd been like, don't ask patients about what they want and end points and bad things. Like, just sweep it under the carpet in a very British way and just give them the treatment. And some people still want that, and that's okay. And if that's what you want, you tell us, and we just give you the treatment. But we have this debate a little bit about you, because it helps us tailor things to what it is that you want. And how much you tolerate a treatment might be different from the man or the lady beside you. How much your ability to tolerate that treatment is, and how much you want that thing that the treatment's there for. I shouldn't assume that just because you've got a side effect that that's okay, and I shouldn't assume just because you've got a side effect that's not okay. I should ask you, how are you getting on with this? And that does take time. And it changes over a lifetime. So what you want today might not be what you want in 6 months or a year or 2 years or 5 years. Your life will change, your wishes will change, and your relationship hopefully can figure that out along the way. So you should be asking for some of these things really from the people that treat you now with medicines, which is why I'm talking about it. So the aim really is to make you feel empowered to think, if I'm going to offer you a drug and you've got a choice to take it or not, do I want it? Is it right for me? Rather than me just take all that power off you and hand you something that might cause you as many problems as it solves. It allows you to take a little bit of the ownership. for this. So if anybody's asking for you to try a new treatment, you should be asking them why. Sometimes you generate that occurrence. So you go in and say, look, I'm unwell, I'm more breathless, can you help me? So that time's obvious why. But sometimes we generate it, I have a scan result, I have a blood test, I have something that I don't like, and now I want to change your treatment. I think a lot of people now want to know, okay, why? What is it that you as the clinician are worried about? What's the risk to me of that thing? What happens if I do nothing? What's going to happen? What happens if I do something? So this treatment you're going to give me, what benefit am I going to get from it? How does that align with the thing that I want from my care? That helps you make an informed decision. But it's not easy. And it takes time and it takes a relationship for us to get this. It also requires us to be a bit more honest with you at times, like we don't know what the risk is here, or we roughly know, but we can't be exact. There are some of you in the room where we know more about their care because you have more common illnesses, like dilated cardiomyopathy, where patients I see day in, day out. We have lots of these people, we do lots of studies where we don't absolutely know, but we know more about the risks of doing nothing, the benefits of the treatment, the harms of the treatment as well. For some of the other conditions, we probably know less so. And I think it's okay for us to say, I'm not quite sure, but here's the reasons why I'm worried about you. And here's what I want to hopefully stop happening. And here's the risks and the pros and cons of why I want to change your treatment to something different. Does that sound strange that you should be treated this way? Is it what you want as patients? So let me pause just for a second. Is this what you want? Most people are nodding. It's funny, some patients, sometimes of an older generation, come to me and say, look, son, just treat me the way you think is right. But most patients, especially as we're getting generationally different, I want this, this is me that you're treating, it's not you. I want to know a little bit more. So I am going to talk to you about this concept of risk here, and I didn't know whether to put this in my talk today because it's probably quite emotive. But after listening to lots of the talks today, I think I've done the right thing in putting it in. Because if I'm going to offer you a treatment, it's a treatment for stopping something bad probably happening to you in the future. And it's quite a hard thing for you to conceptualize. Like, is this bad thing going to happen tomorrow? A year from now, 10 years from now? How likely is it? And we probably don't empower people very well to make these decisions with their treatment. So let's try and take this down as if I'm explaining risk to my children. And I'm going to try and pitch you a level of what risk looks like and what the kind of decisions go on in the heads of the people that are treating you are. So let's imagine a risky situation. Let's imagine that this room that we're in is a nursery class, okay, and we're all children, and somebody's left the door open. And outside that door, there's a road. And on that road, there's a bus. Okay, so I think we'd all realise that some of those children are at risk. Okay, the things that bring the risk in this scenario are actually the frequency of the bus, first of all. So if this is central London, that bus comes along every 30 seconds. If it's the Highlands in Glasgow, the Highlands of Scotland, that bus comes along once a week. Okay? So there's risk in both scenarios, but the risk's not the same to each of the children in the room. So this is why it's quite hard when I give you a talk to lots of different people with lots of different problems. It's going to be hard for me to answer my questions today because I don't really know any of you. And I suppose that's one of the things that I'm telling you. But there is a thing about understanding that different schools in this situation have different risks. So dilated cardiomyopathies versus HOCMs versus something else, peripartins. We can have different levels of risk here because they have different frequencies of a bus that we might want to stop. Now, in this scenario, the bus essentially might be the cardiac event that we're trying to stop. We don't want that child getting hit by that bus. The children are the patients. The door or the gate that I might build is the drug that I want to give you. The other two things here that bring the risk are the number of children in the room. So if I ram 100 or 200 children in this room, it's more likely that one will leave than just putting one child in it. and the longer they're in the room for, because there's more buses going past them. And this is essentially what we're trying to look at when we do a clinical trial. If I build a door, say for a week, do I stop any of the children leaving, getting hit with the bus? Because lots of them might stay and be happy, lots of them might leave and never get hit. So how long do I need to build that door for to stop one getting hit with the bus? And we call this a number needed to treat. So we know that maybe for every 30 children for a week, that I stop one getting hit with the bus. And this is a kind of economic analysis that we do of it, and it helps us let us know whether it's clinically or it's cost effective. It's kind of horrible, actually. It puts a value, pounds and pence, on your life. But it's what we do with all of these interventions. And it lets us know of a rough line in the sand that maybe if I offer you this treatment for long enough, you have a 1/30 chance that I'll stop that thing from happening to you. But it doesn't tell you, the individual, whether it's you. Well, is it you that doesn't get hit, or is it you? It's a kind of population effect. It's a line in the sand, like average. You're the average person, so you've got 1 in 30 chance. But life doesn't look like that. You guys are all individuals here. You've heard this from a few of the speakers earlier, Perry, Elliot and others, about individualising care. So these children in this scenario are different. You as different people sitting in this room are different. You have your own individual risks that we have to take into consideration. So here's my 3 daughters, all when they were roughly about 2. They all kind of look the same, don't they? Look at them. They've all got wee squashy noses and kind of like wild, kind of mousy hair, podgy little cheeks. They kind of look the same. You probably couldn't tell one from the other if I sat the 3 of them in front of you. But they're all quite different. They're quite different in this scenario. If I sat my 3 daughters in this room, one of them would say, yes, Daddy, I will not go towards the door, and they will not go towards the door. One of them would sit and say, I won't go towards the door, and they'd eventually, because they get bored, and one would run towards the door as soon as I left. For all, they look the same. Now, I understand the individual characteristics of my daughters, and that's why I understand their individual risk factors. Okay, so the relationship as their father over time helps me understand which person's more likely to navigate towards the risky event. And this is what I'm trying to do to you as a clinician when you come to my clinic as well. I'm thinking, is this guy average, or which factors does he have that means he's more likely to go towards that thing that I don't want? And that becomes tailoring the treatment to you a little bit more. And then when I offer you advice, I say, I think this is the rough line in the sand, a 1 in 30 benefit, but I'm a bit more worried about you because of these features. And I think your risk is higher than that. So I try and tailor that advice a little bit more towards you. And that's treating you as an individual rather than just a line in the sand. But it takes me knowing you and knowing what you want as well to try and achieve that. This is obviously a cartoon situation that I've given you here as well. It's much more complicated than this. There's multiple things that can happen to you. There's multiple ways that you can go. There's multiple endpoints. And sometimes when I give you a treatment, I open one door, or close one door, and open another. And let me give you one example of this, and it's not from cardiomyopathy patients now, but it's just to try and help you understand this. So I see a lot of people with coronary heart disease in the clinic that I do a couple of times a week. I see cardiomyopathy patients as well. And one of the things that I'm asked to do is to treat their cholesterol a little bit better. That's probably something that some of you might be on cholesterol tablets, or your partners, or whatever it might be. So we have a new cholesterol drug in the market that can stop the incidence of going out and getting hit with the heart bus. So I know that this new drug, for every 3 years that I put people on it, if I had 200 children in the room, would stop 3 of them getting hit with the bus. So it's tiny, the effect. 3 children, 3 years, treat 200 patients, you stop 1 heart bus. But what I do is I'll open a couple of back doors, and I'll make 4 of them get hit by a gout bus, and 4 of them get hit by a gallstone bus. Now, how do I tell the patient at my clinic, how do I don't make them understand, how do I help them understand that, I could make your cholesterol a bit better. That might stop your heart attack risk, but it might cause you other problems as well. I don't believe we have these conversations very well with patients like you guys when we bring them into clinic, because we're all pressured. And I think some of this talk is to help you ask the right questions when you go to see the people that are treating you. It's going to be hard for me to answer any questions for you today because I don't know you. But thinking about, well, why are you worried about me? What is it that which bus is it you're worried about? What do you think my chances are? If I don't take your treatment, what do you think my risk is? If I do take my treatment, what do you think my risk is? If I do take your treatment, what do you think other problems are you going to cause me? And I think that helps you get to an informed decision of whether you want the treatment or not. And it's not just me writing your prescription and telling you to get out. So this is hard. It requires a relationship. It requires honesty. It requires me sometimes saying, I don't know, but here's the reasons I'm worried about you, and here's the thing that I'm worried about. And from what we do know, here's roughly what we think the risk is going forward, doing or don't do. You can imagine this takes quite a while for us to do properly in a clinic-type setting. But it doesn't matter, actually, whether it's the drug, which is my job, whether it's the defibrillator, whether it's the cardiac transplant. We should be sitting to you and helping you really understand the pros, the cons, the do's and the don't do's. And we have to then align that up with what you want. So there's no point in me offering you this treatment if what you really want is a baby and I'm going to take you off this treatment in 2 months. There's no point in me offering you this if it's going to cause you 3 other problems that you absolutely don't want to have. It depends whether I'm empowering you to help me be the advocate for what you want. And that's probably one of the hardest things in medicine for us to do properly with you today. Forgive me if I'm talking about weird things today. Do people find this weird? Stephen Kirkham asked me down to talk to you about some of these things today because he thought it would be a different pitch for you, I think, to understand and to listen to some of this. I'm probably going to talk to you about equally weird things as we go. It's maybe my Glaswegianism, so again, if you don't like it, stick your hand up. If you don't like it, I can't do anything about it, I'm sorry. Medication adherence is equally complicated. I can give you something and tell you to take it 3 times a day, but will you take it? It's a bit like taking your antibiotic. Maybe you will and maybe you won't. And there's a few things that we need to help you think about along the way. And I'm going to show you some patient-led, well, it's not patient-led, but I'm going to show you some qualitative research from patients in Glasgow as part of this. So listening to people about why they don't take their drugs. So we worry about people not taking their drugs, especially patients like you. So let's not beat about the bush again. Like, if you come to my clinic and you tell me you're not taking your drugs, I worry. Because I worry that you're going to go out the door and get hit by a metaphorical cardiac bus. And we know in most cardiac patients that when you dip below taking your tablets about 80% of the time, then you start to probably become clinically significant. You're not getting the benefit from them. You can miss the odd dose and it probably doesn't make much difference. But most people, if you're missing more than 2 out of 10 doses, you probably are now dipping into a subtherapeutic range. And we write all these fancy academic papers about, oh, isn't this bad? What will we do about it? Don't go to the pharmacy and get one of these blister pack boxes for everybody. And I'll try and explain the reasons why in a minute. You can get them if it's what you need. But I'm going to try and convince you that actually it's your life sometimes that doesn't help you. Maybe we should talk to you about your life instead. So there's 5 reasons why people find it hard. And I'm going to show you examples of each of these, by the way, in a minute, to take their drugs. Some of them are factors about the drugs themselves. Like, I don't like it. It gives me a side effect. Some of the things are about the patient. I forget, my life goes a different way. Some of the things about the condition. I'm tired all the time. I fall asleep and I forget my stuff at night. I've got heart failure. I'm knackered. Some of them are about the health system. That bloody GP I can't get through in the morning when I phone. Some of them are about social things. I can't afford the bus to go and pick it up. So what's the point of me just sticking all of your drugs into a box? With nice blisters and times of the day if I don't ask you which of those things it is that stops you from taking them. Okay, there's no point in me sticking them in a nice fancy box if you can't afford the bus fare to go and get it. Or if you're falling asleep at night, you're still asleep. Doesn't matter if it's in a box or if it's in a packet. You're still asleep. And lots of these things overlap and lots of the other conditions. But I want to show you this in real life of what this looks like in Glasgow. And I don't know if anybody's ever been to Glasgow. It's a nice city. Come, we're all very friendly. But it's kind of deprived. You know, it's live fast, die young kind of city. So I'm going to show you this, and I'm going to leave some of these slides up for a wee bit longer, and we can look through them. So we found through my work about 15 patients that weren't taking their jabs. So we'd proven it. They admitted it. Like, there was lots of complicated reasons. We brought them in and we interviewed them all one-to-one. We kind of said, we had a structured question for going through in a discussion, and we published the findings. Why? So that we learn how to help more patients in the future with these kind of scenarios. So let's go through the different factors that people told us. Lots of my patients are I was going to say elderly, but older. And they often have multi-morbid conditions with lots of different things wrong with them. So lots of them told us, I can't see the thing, I can't get it. I swallow it and I've got reflux and I just vomit it back up. They've got lots of other things wrong with them. So their heart's not the only thing wrong with them. Your heart's not the only part of your body. So if I'm going to give you lots of drugs, there's lots of other things that might impact on how you can ability to take it. So that first one makes sense, I think. So again, this is why me knowing you helps, because I know not just about your heart or you're here to see me take us your heart, I know those other things. And that's why I can tailor this a little bit better to you as an individual. We underestimate the burden of treatment. Sure, I can give you all these fancy drugs to hopefully help your heart, but, I'm a human being, so when you give me 10 or 12 or 15 or 20 or 30 different tablets to take, it's quite complicated, I've got all these boxes and I don't know which it is. There was I maybe dropped one on the floor, I can't remember, I got mixed up, it's 12 o'clock now, did I take it, did I not? It's quite an undertaking. It's quite an undertaking to have a chronic illness, especially if that's one of a number of chronic illnesses. So again, it can be a burden, the burden of us giving you all this health interventions shouldn't be underestimated. There is a thing about literacy, about us educating you about what's wrong with your heart. Oh my God, they said they had heart failure. I thought that meant you were dead. I only really found out on the 8th day in hospital what it meant. This is going to take time with you to get your head around these things about why we think, if we've both come to the conclusion that we want to take them, that what's wrong with you and why it might benefit and what happens if you stop them. Well, if we don't get that right, a lot of people give up in their treatments and then maybe don't get the benefit from them. And that's what I think organisations like this are good for. They're good for lots of things, but they're good especially for bringing us together and having this open debate a little bit more about what's wrong with you. So health literacy, again, is, I think, fairly okay. Oh, wow, trust in the NHS. I don't like my GP. I fell out with them. He didn't treat me right, so I said, stuff him, I'm not taking any of my tablets. I mean, who comes to harm in that sense? I mean, not the GP with his nice bottle of Rioja when he goes home. It's the patient. Oh, I was having problems with my pharmacy, it closed down, I couldn't get there, I didn't like them. Sometimes we are the problem in the NHS and how we're treating you, because that relationship's not right. We're not treating you very well and you take the hump and you stop the medicines. Please don't do that. Go and find somebody that treats you properly and treats you with respect. Go and find a different GP, go and find a different pharmacy. There are people hopefully out there that will try and treat you as a person. But yeah, we cause this in you sometimes. Socioeconomic factors, these are the sad ones. I used to have family that helped me, but I fell out with them, and now I don't have anybody to go and pick my drugs up anymore. You don't notice when you live alone actually how puffy you've got or how bad your breathlessness is, because there's nobody to care. Look at the bottom one. I don't want to get political on you, but I have to go for my benefits assessment. And the only time I don't take my drugs is I don't take them in the few days beforehand because I have to prove to this person how bloody sick I am. I mean, that's just sad. Imagine trying to make your heart condition worse to get your bloody benefits. And that's horrific. It's horrific. So there are socioeconomic factors here. Like in Glasgow where I work, people are poor. They are poor. I come from a very affluent part of Glasgow. I'm not the average person. They are poor. Autonomy. You've got your life to lead, don't you? You don't want to be thinking of your drugs. You want to be getting on with your life. Sometimes your life's better than your drugs and you forget. Yeah. And you don't want that taken away from you. That's right. Your expectations. I'm from a poor area of Glasgow. Everybody dies in their 50s of heart disease. It's normal. It's not normal. Okay? We have to change your expectations slowly. And that's why, if you get the right clinician, we can help you. So if you're not taking your medicines properly, if your partner's not taking your medicines properly, talk to them. Treat them as a human being. Find out what's wrong. Go through different things. Be compassionate with them. Try and understand and get below that. Don't wag your finger. Don't stick all their medicines just in a box as if all they need is structure. Maybe they need structure. Maybe that's okay. But maybe they just have something else wrong that you actually have to delve a little bit deeper with. Right, the last thing I want to talk to you about is over-the-counter drugs and different bits and bobs. And then you can ask me anything you like at the end. Being a patient's hard because we're probably giving you lots and lots and lots of different treatments now. And some of these treatments all interact with each other. Now again, we know that if you have heart failure, and that's that you probably all patients are now on over 5 medicines. So, it's everybody now. It's hard because drug A and drug B sometimes fight against each other. Again, this paper is from patients with dilated cardiomyopathy, so it's a little bit different. But we know that there can be a lot of drugs out there that you're getting for some other element of your body that can be harmful for your heart or can fight against the other medicines. And you probably would benefit from somebody taking this bigger picture of you, not just thinking this is a guy just with a heart problem. Well, no, hold on a minute. I'm a human being with lots of good points and bad points, like going to look at my drugs as a totality as well. Because there can be other medicines. And you remember that this is only for a certain group of patients that I've got up here. It's not for everybody in this room. But the point is there are certain medicines sometimes that can have heart effects. And the same is true for the medicines that you'll buy from over the counter. Okay? So you can walk in and you can buy things for headaches, things for urinary problems, things for periods, things for migraines, things for bowel problems, things for cystitis that all potentially interact either with the medicines you're taking for your heart or with the heart itself. They don't assume that just because you buy it doesn't mean it's not harmful. Okay? Still a drug. Just a drug that we've changed the law in so that you can buy it. It doesn't mean that it isn't going to have some effect. So this is why I'm saying get in a relationship with your community pharmacist as well. Okay, I'm not a community pharmacist. I'm a specialist pharmacist in a tertiary hospital. Okay, but find a community pharmacist you like that treats you with dignity, that offers you a good service, and get a relationship that they know what's wrong with you, because they can help you with this over-the-counter things as well. I'm going to test you a little bit with my last few slides, because people normally ask me about herbal preparations as well. So, anybody know what this is? It's foxglove, and which medicine is it? It's digitalis. Okay, so you've passed one. That was the easiest one. Okay, you've got 2 more. Okay. What's this? It's a willow tree. And which medicine? It's aspirin. Well done. So you've passed the second one. And here's the third one. A little bit harder. It's a snake, yeah. I'd be like a stingy Scotsman. I'll give them a fiver if they know which snake it is. It's a viper. Well, I'll need to find a fiver. So this is a Brazilian viper. Does anybody know why I'm showing you a picture of a Brazilian viper? So it's MD on Ramipril, Enalapril, Captopril. Yeah. Okay. So when a Brazilian viper bites you, you go into low blood pressure. You go into essentially hypotension. Okay, and we got the venom, we extracted it, we made Captopril, which is the first agent from it. Now, why am I showing you this? Because people that think natural products mean that they're good, well, marijuana's natural, okay? Poppy seeds are natural, and we make heroin from them. Like, just because things are natural doesn't mean that they have no effect on you, no effect on your body, no effect on your heart, no effect on your other drugs. Now, we can argue this point, and I'm not here to tell you as individuals whether you can take any of these things. I'm here to tell you, speak to people who are treating you about them. Because it's hard for us to go and think, what's natural, it's fine. It's no snake venom, and so is willow tree. If anybody's taken dapagliflozin, it comes from apple tree bark. Okay, so SGLT2s, dapagliflozin, well, go and give me a pint of cider and watch me pee in an hour or two. That's how we made SGLT2s out of them, okay? All of the stuff that's been good, really, in nature, we've turned them into proper pharmaceutical drugs. So don't be thinking I can take any supplement or any, thing known to man just because I can buy it and just because it's natural. It's not as simple as that. You have to be seeking advice from somebody that knows what's wrong with you, and that's somebody that knows what you're taking. Okay, so this is my last slide now, and then you can ask me anything that you like. So this probably was a little bit of a different talk from you. It's probably maybe not about pharmacy at all. It's about treating you as a patient around the edges of the drugs that you might need. And what are my take-home messages? My take-home messages are that we should be including you in a partner in any decision, so that you understand why we want to treat you, what the risk of doing nothing is, why, if we give you a drug, that might help you. So how much does it cut that risk of you getting out and getting hit by an event, over what time? And if it does that, what harm does it come with? So is it going to cause me some other thing? Or it's not going to absolutely, but what's the risk of that other thing happening to me as well? This is the way of us really treating you as an informed patient, human being, and that this is actually medically legally is vital for informed consent in a medical legal sense. This also helps adherence, getting to know you, getting to understand you, treating you like a human being, asking you what's wrong, making sure that whatever we give you aligns with what it is that you want out of your life, helps you take your tablets as you're supposed to. If you're not, speak to somebody about it, because it's complicated. If you're on lots of other therapies, you should be speaking to people periodically about whether they're good, whether they're bad, what they're doing. Because if somebody's just looking at your heart, there can be other medicines you're doing that's interfering with your heart and your heart drugs. And if you're buying things over the counter, or you're buying herbal preparations or any of this stuff, that's fine. But make sure that you're buying it from somebody that knows the whole picture of you and is giving you some reasonably unbalanced advice. So thank you for your time, and delighted to take any questions from you.
Thanks very much. Can you hear this? Yeah. Thank you, Paul. That was very interesting. I do have one question here.
Yep.
I'll let you read it, and I'll gather any further questions. If anyone has one, put your hand up, and I will...
So I'm going to read it out. So when you have a heart transplant, you're taught how to take your medicines, why, you have a book to keep. Maybe this might be something that cardiology could adopt. So I work with patients essentially pre-transplant is part of my normal job. So I work with heart failure patients, and normally when they get to transplant stage, we hand them over to the lady you might have heard from earlier on. Certainly for the form of heart disease that I normally work with, which is reduced ejection fraction heart failure, we have specialist nurses, and we really should be bringing you in and giving you booklets and working with you and writing things down and doing that sequentially over time with you. We're not perfect, but in all areas of the UK, for heart failure patients and cardiomyopathy patients, we really should have that thing around you. For kind of more garden variety cardiology, for coronary heart disease, high blood pressure, diabetes, we're not very good at these kind of things. We're all a bit stressed, and we kind of tend to write the treatment and just get rid of you and get you out. But I think that's why people don't comply, people don't understand, people go sideways. Yeah. So I think we can, and for the people in this room, you should be getting this kind of specialist MDT and somebody spending a bit of time with you as an individual and scoping and writing things out for you. The only thing is, that won't help everybody with everything for some of the reasons I've spoken about. Some people have other problems, but this certainly helps.
I think if you have got questions about your own personal drugs, then you definitely, they don't understand an aspect of it, you definitely need to make time with your pharmacist or your cardiologist to talk about it, and put yourself first.
Yeah. I mean, who here is seeing a specialist MDT regularly? Are you seeing a specialist multidisciplinary, or are you mainly? Who's mainly the GP? Is that your main caregiver, or is it coming to see somebody like me in a tertiary hospital? So, who would normally ask the person in the hospital, and who would normally go and see their GP or something first? Okay, one or two. So certainly the specialist teams like come and see me, my colleagues, the consultants, the nurses in the hospital, we should be able to sit you down and do these things more sequentially over time with you.
I mean, I don't know about you, Paul, but I'm working in the rapid access chest pain clinic, and I have 20 minutes per patient. It's not enough.
I mean, it's not enough. I probably have 20 minutes with a patient as well, but I would see them sequentially over a number of months, like a handful or two handfuls of times. So, I might have 15 minutes with you today, but let's pick that up next week again, or let's bring your stuff in, or what other questions you have. Rapid access chest pain is much harder because you're probably in, out. And this is why it's hard for you to really feel that you can make an informed decision, because we haven't informed you. We haven't informed you of the risk. We haven't informed you of the benefit. We haven't informed you of the harm. I would hope with cardiomyopathy patients we are doing the way I've pitched you today, and if it's not, I would be asking you for these questions when you go to clinic.
Can I just add also, Cardiomyopathy UK have 3 nurses, you might have met them out there, and there's always somebody on answering the phones available, I think between 8 and 4, if I'm not wrong, and they will be able to help you as well if you can't get what you need. Any questions? I'll just pass the mic over.
Please do.
Stay there. It's fine. But do stand up.
Hi, this is not actually a question. It's more of an observation. I'm fortunate enough to live in a rural community in Somerset. We've got a very large GP practice. And one of the GPs retired. They couldn't get another GP in place. So they've got a part-time GP, and I think they've got a full-time clinical pharmacist. So over the last couple of years, I've had them ring me up and telling me, you need to change your blood thinners. I had a very long discussion about them, that I should take statins. They've also arranged blood tests as well. So they've stepped up and picked something up. So maybe I'm fortunate of where I am, but in my case, that's been a huge asset, because they're engaging that there where the GPs wouldn't, and they're more up to date.
And to be fair, that's why I'm giving this talk, because there's lots of my colleagues around the country. So I'm a kind of cardiac nerd in a specialist hospital, but what lots of you in this room will have access to is a general practice-based general clinical pharmacist that should be able to cut through 80% of what I've told you today. And if they don't, they should have a route into somebody like me that they can ask. So they are becoming quite a good asset for each of you to go and spend a little bit of time with. They're just at the nerdy cardiac, knowledgey part, maybe less experienced than me, but they're brilliant for your average 80% of what you need to help with. So go and seek them out. It's brilliant.
It's just going on from that point. My daughter is a clinical pharmacist in a GP surgery. I think a lot of patients don't actually appreciate how good that pharmacist is. And they want to see a GP. They won't see the pharmacist. And I think that we need to educate people in that respect, because it will help. They're experts in the field.
Absolutely. So they've got different pros and cons and different strengths. So if you've got a brand new problem, like I've got something wrong and I've no concept of what it is, you're probably better going to see the GP. But if you are chronic disease and you're on a treatment plan for it, and you're maybe still in the optimization stage of that, or you're developing problems with the plan, then that pharmacist is a very good member to come and have the kind of debate that I've tried to have with you in the audience today, and that they should be skilled for most common forms of heart disease. And if they get to a rare condition, they might know who the equivalent of me is, that they can go and seek out, essentially.
Just thank you, Mike.
In general, if a lot of people that have got heart disease, cardiomyopathy, have got a lot of other comorbidities, just thinking in general, if those particular people aren't always seeing specialists, for example, I've got fibromyalgia, I've got loads of other stuff, I'm not seeing any specialists for it. If I start a new medicine, or I've got a pain somewhere or there's a problem somewhere, I always hear it's probably heart, it's probably fibro, it's probably this, but there's no actual, when we were talking about MDT, there's no actual MDT around it. I've got my heart failure specialist and I've got my, everything else specialist, but when it comes to medicine, there's no central place. What do we do if we need a central
And this
team?
lady at the back, that's why her daughter does the job that she's done. So rather than me, so I am I only really deal with heart disease kind of pharmacist, but this lady's daughter I'm pretty skilled at all major conditions. So you're a good person to actually go and see in your practice, and you will have one probably, you just not know they exist. Will be somebody like that.
I did, and then they sent me to the consultant, and then the consultant told me to speak to the GP, and the GP sent me back to the consultant. So I'm asking you for it.
Happy to talk to you at the end, but yeah, it is certainly frustrating to get past from pillar to post, so I fully empathise with you.
Do you have a question? Sure. Sure.
I'm happy to talk to anyone at the end, like for 5-10 minutes, if you don't want to ask questions.
Sorry, I think it was just a bit like what this lady asked. Where do you find that clinical specialist? Because I see a heart failure nurse, and they need sign-off from the consultant, who you don't see that regular, every 6 months, 12 months. I've got a pharmacist at the GP practice. I don't know if it's a clinical pharmacist.
It will be.
But they would say, if you're looking to address this symptom in a more progressive way, say, that might be a medicine change, I couldn't do that. Your cardiologist would need to do that. But yet you're not scheduled to see them for, say, 8-9 months.
Yep.
Do you get what I mean? And you're not going to get in touch with the secretary to say, can I get in early? Because, I want a medical review.
Yeah. So these things are hard, first of all. I don't have answers to all of them. But these people shouldn't be passing the buck. We've lost a little bit of the old-fashioned communication in medicine. If I said 30 years ago things would have been worse. 30 years ago, some of the things would have been better, because in that case, you'd have picked up the phone to someone and said, I've got this young lady, and I think you know her. I don't want to waste her time and send her all the way to you. I was going to do this. Do you think that's okay? We've lost a little bit of the common sense of clinician A and clinician B in two different teams just picking the phone up to each other. So if I were in your situation, would sometimes say, look, don't send me over there. Can you just not pick up the phone to that person, and I'll come back in tomorrow or later in the week? That certainly, if you were my patient and somebody from general practice phones, I'd be delighted. Yeah, I know the lady very well. Yeah, sure, try this. Or no, actually, going to try this, and tell her to come and see me in a month or whatever. So the ability of common sense between your clinicians, I think it's okay as a patient to advocate for yourself and say, hold on a bloody minute. Don't be sending me for another referral to go to the end of an 18-week treatment waiting list. Can you pick up the phone to that person over there while I'm waiting to go back in 6 months? So some of the older cardiologists that I work with tell me that we've lost the art of picking up the phone to people, and I think they're right. Like here's a computer referral, don't need to worry about you anymore. Cause I've sent some computer message off for you, and I'll just wait randomly forever to appear. So I think to be vocal and say, look, can you not pick up the phone to that member? I think with a couple of other healthcare professionals in the room, you would, Stephanie, you'd be quite happy ever in the chest pain clinic to take a phone from a GP or a practice nurse.
I would be quite happy to take the call, and I'm also happy to consult with a consultant if I needed anything.
Yeah. So don't, if people look like they're passing the buck, can you just tell them? Just tell them and say, well, hold on, can you not just pick up the phone and I'll come back in a few days. I know you can't do it right now, but you can do it over the next day or two for me.
I do. I live in Tower Hamlets, 15 minutes down the road, and they will pass the buck back to me and say, well, no, we don't have time to do that. Sorry. Yeah, no, I live down the road, and this area is notorious for them not entirely giving as much love as they should. So they'll literally just be like, no, sorry. I mean, I'm very strong on personal advocacy. I'm a single parent. I have to be. And a lot of the time, I'm pretty much just getting like, no, that's not our job. And I'm like, well, it is. And then they say we don't have the time, and then I end up having to send the email, and then I don't get the email, send the second email, then I go back to the GP, and it's just a constant. So we have tried, and I know it sounds like I'm sort of knocking down the advice, but it's a constant.
I share all of your frustrations. I empathise with all of them. And I think you're right to advocate for yourself and to be, I was going to say grumpy. Grumpy's not the right word. To ask for more when you're getting a substandard service.
Would
Yeah,
it
stand your ground.
be
You're the patient.
What about changing GP? Is that an option?
I did. I'm hoping they're a bit better. I only recently changed, so.
All right. Okay. Thank you.
Yeah, I'd just like to say that with relation to what this lady has been saying, the letters that you get from the hospital have phone numbers on them. And very often, last week there were 4 different numbers on the letter. None of them picked up. None of them. I mean, what are you supposed to do? I actually went to the hospital. Luckily, I could because I'm in London and the hospital's in London. But for people who live a long way away, and the phones aren't being attended, what are we supposed to do? I mean, it's a real frustration. Nothing.
I think you could. I share your frustration as well. I'm a patient, but I generally just look them up and email them. Yeah. So, I mean, have you tried email? Well, you just have to Google or ring up a secretary. You could ring Cardiomyopathy UK. As I said, they've got the nurses there that may be able to help you, and may be able to help you get access with a different phone number, I suppose. But yeah, I share your pain. Yeah. Any other questions? I'll just move over here. We've got about 5 minutes left. So,
just on a practical level, I'm newly diagnosed dilated cardiomyopathy. Just a quick question. I've been dealt with by a very good cardiologist and a cardiac nurse. My issue is who's actually driving the medication treatment, because at the moment, because my GP has to sanction the repeat prescriptions, they're now I've been a year and a half on the medication with all the guidance with the hospital, but the GP now is starting to question some of the medication, i.e. not repeating prescriptions on some of the medication without him being involved or her being involved. Now, this seems to be typical from what I've spoken to other people with large GP practices. So, and I'm just wondering, at the moment, I've just gone straight to the cardiologist and just gone, look, my medication's been interfered with, and a letter is sent, and then all of a sudden I don't get any communication with the GP for about 6 months, and they just keep repeating.
Okay, so I'll try and answer this in generic terms, because it'll be a little bit different depending on the country that you're in. But normally, for most heart failure teams that are dealing with DCM patients, the specialist nurse and the cardiologist will be driving the plan. They'll also probably sometimes offer you and initiate it, so they might give you the first and the second prescriptions or whatever things. Locally within that authority, so the hospital trust and maybe the PCN or whatever around it, there should be a joint working arrangement that, this person writes the first 1 or 2 or whatever prescriptions, and once they get to X months, this person takes them over. And every time you're seen, the specialist team will be writing an electronic letter to say, I've saw this chap at clinic today, this is how he is, I've now started him on this medicine, I'll follow him up. But there should be a joint working arrangement in the back that once they get to a certain line in the sand, that these two partners have agreed that the transfer of care happens. I don't know your area and I don't know your trusts involved, but there should be a joint working arrangement, and there should be communications at every stage. So the GP should never look at you thinking, I've no idea what's happened to you recently. Whether he or she has been doing it or not, there should be communications at every stage into the practice with an ultimate agreement of when the care gets handed over. So it's hard to know what's gone wrong in that case. Look, this conversation maybe for out there, the NHS is a hard place just now. But I don't know what's gone wrong, because your nurse and stuff should lead it, but there should be a joint care arrangement of taking it over at a certain stage.
There doesn't seem to be an issue, because once the interference has sort of been clarified, then the interference goes away. But it just seems to be, I don't know whether it's to do with the way, because I don't really quite understand how the GP gets involved with the actual care.
Yep. So the GP, when they get a letter in, would have to action that letter and put any changes on, and depending on what's written in the joint care agreement, they might have to do some of the monitoring around it. It depends what the joint care arrangement between the PCN and the trust have agreed. But this should all be laid out in almost like a contract between those two parties. So there should be no ambiguity, and there should be, when they get a communication in, that they update their systems. So the process just has failed at that stage.
That's what it feels like, because most of the sort of conversations I have is I'm just always constantly told by the GP of the what's the word? All the
contraindications.
Of particular medicines. Well, if that was the case, but they're not doing any. The problem is they're not doing any of the monitoring. The hospital is doing the monitoring and is happy with the monitoring. So there's some sort of it's like they want to be involved, but they're not involved.
It sounds like poor communication between both parties. So what you should have is, like, I saw this guy and I'm going to go offline off kilter a little bit normal, but I'm doing it for these reasons, and I'm monitoring it, but I'll still pass you over. So it is unusual, but I will let you know when I monitor, and I'll let you know when to pick up. Sometimes the hospitals, and that's my kind of teams, can be bad at just saying, I saw this guy at clinic today, I've changed his drug, without explaining you've done it a wee bit unusual, and that I've checked a few things that you can't see. So it just sounds like poor communication, if I'm being honest, between your parties.
It wouldn't be, not to be, it wouldn't be a cost then.
Could be.
Now, at a medicine level, they will have sometimes joint care agreements about when the medicine cost transfers over. It depends.
The reason I'm asking is from my sort of research, I'm on a fairly high-end, good practice medicine.
Yep.
That's good to hear.
Okay. Happy to talk to you just after we finish just now. That could be the case, but in Scotland, that would be unusual.
I'd just like to say thank you to Paul for giving us that great talk, and thank you for your wonderful questions, and I hope we've answered some of your questions. Paul said he was available afterwards, so do get him if you need any more information. So now it's coffee time, or tea time, and then we're meeting again in about half an hour or so. Thank you very much.